Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. So in this video, I will be going over urea cycle disorders. Let's get into the details. Now the ammonium ion is toxic to central nervous system. So when there is excess presence of ammonium ion in the blood, and this ammonia will lead to changes in the central nervous system. So hyperammonemia, which is accompanied by increase in glutamine. So it will lead to a depletion of 𝗪𝐴𝐾𝐴 because whenever there is hyperammonemia, so ammonium ion will be fixed to 𝗪𝐴𝐾𝐴 to make glutamate, which is done by glutamate dehydrogenase enzyme, and glutamate is fixed with one more ammonium ion to make glutamine, and that is done by glutamine synthetase enzyme. So because of this, there will be elevation of glutamine in the blood. So there will be elevation of ammonia in the blood and there is elevation of glutamine in the blood. So that's why there will be hyperammonemia and also there will be increase in glutamine, but there will be decrease in 𝗪𝐴𝐾𝐴 and eventually glutamate. So these changes in the cell, especially in the neurons, where there is increased ammonia which has got a neurotoxic effect. Increase in glutamine will have an osmotic effect on the neurons, leading to changes in the neuronal metabolism, including changes in the mitochondrial permeability. Decrease in 𝗪𝐴𝐾𝐴 will have an effect on energy metabolism because 𝗪𝐴𝐾𝐴 is an intermediate in the TCA cycle, and glutamate is a neurotransmitter in the central nervous system. So these changes will have a greater effect over a neuron. So what happens here is, in the neuron, there is increase in ammonium ion, increase in glutamine. Always these two are associated. Like whenever there is increase in ammonium ion, there will be increase in glutamine in the blood. That means there will be decrease in 𝗪𝐴𝐾𝐴 in the cell, and also there will be decrease in glutamate because glutamate is the one that will be converted to glutamine. So there will be changes in the central nervous system because of all this. Now the ammonia toxicity will lead to brain swelling. High glutamine levels will alter the permeability of the mitochondrial membrane, thereby changes the mitochondrial metabolism, eventually lead to changes in the cellular metabolism. Increase in glutamine will lead to decrease in 𝗪𝐴𝐾𝐴 and glutamate. So that means TCA cycle will be decreased. And also some of the changes that are going on in the central nervous system, especially in the neurons, is there will be activation of N-methyl D-aspartate receptors, because these NMDA receptors are the ones that are involved in causation of seizures, that is convulsions, which are one of the signs that is seen in hyperammonemia. And also changes in the glutamate nitric oxide cyclic GMP pathway, leading to activation of GABA action, contribute to deterioration in the intellectual function, decrease in consciousness and coma. So these are molecular changes in the neuron, how increase in ammonia will lead to alteration in the neuronal function and thereby giving rise to signs and symptoms. Now let's move on to see disorders of urea cycle, which can be classified into inherited hyperammonemia and acquired hyperammonemia. Now in the inherited hyperammonemia, like all urea cycle enzyme deficiencies, they follow autosomal recessive inheritance pattern except ornithine trans-carbamylase deficiency, which will follow X-linked recessive inheritance pattern. Now the inherited hyperammonemia can be of 5 types because there are 5 enzymes in urea cycle. And number 1 is hyperammonemia type 1. That's because of deficiency of Carbamoyl phosphate synthetase 1, which is a very first enzyme in the urea cycle. Number 2 is ornithine trans-carbamylase deficiency, which can also be said as hyperammonemia type 2. Number 3 is citrullinemia because of deficiency of 𝗂𝐼𝐼𝐻𝑖NOSuccinate synthetase enzyme. Now the number 4 is 𝗂𝐼𝐼𝐻𝑖NOSuccinate aciduria due to deficiency of 𝗂𝐼𝐼𝐻𝑖NOSuccinate lyase enzyme. And number 5 is hyperarginenemia due to deficiency of arginase enzyme. These are 5 inherited disorders that leads to hyperammonemia. So one more time, we have hyperammonemia type 1, first enzyme in the urea cycle is deficient. Hyperammonemia type 2, second enzyme in the urea cycle is defective. Citrullinemia, third enzyme in the urea cycle, that is 𝗂𝐼𝐼𝐻𝑖NOSuccinate synthetase enzyme. 𝗂𝐼𝐼𝐻𝑖NOSuccinate aciduria because of deficiency of 𝗂𝐼𝐼𝐻𝑖NOSuccinate lyase enzyme, fourth enzyme in the urea cycle. Hyperarginenemia, fifth enzyme in the urea cycle, that is arginase enzyme, is deficient. Now a presentation of urea cycle disorders. So they can vary in severity because as they go from number 1 to number 5 reaction. Obviously the number 1 reaction where ammonium ion is free and it is going to be condensed with bicarbonate to make carbamoyl phosphate. If there is a deficiency of CPS-I enzyme, very first enzyme in the urea cycle, if that is deficient, it will give rise to most severe hyperammonemia. So as you go from number 1 to number 5 enzyme deficiency in urea cycle, so the severity of disease will decrease. So some of the presentation in urea cycle disorders in general is child will have feeding difficulties, lethargy, irritability, avoidance of high protein foods like protein intolerance here, intermittent ataxia, irritability, and it may lead to severe mental retardation. Now the full term infants who initially appear normal then exhibit progressive lethargy, hypothermia, apnea due to high plasma ammonia levels. Clinical features and treatment of all 5 disorders of urea cycle are similar, although severity of signs and symptoms vary. Earlier the block, as I said, more severe is the disease. And the significant improvement and minimization of brain damage can accompany a low protein diet ingested as small frequent meals to avoid sudden rise in the blood ammonia levels will help. Coming to the most common urea cycle disorder among the inherited hyperammonemias, the most common one is the ornithine trans-carbamylase enzyme deficiency. The ornithine trans-carbamylase enzyme deficiency follows X-linked recessive inheritance pattern because the enzyme ornithine trans-carbamylase, its gene is located on the X chromosome. The age of onset is usually after the childhood, otherwise child is normal. So the laboratory diagnosis includes hyperammonemia, which is usually more than 2000 milligrams per deciliter. Very low blood urea nitrogen level because urea cycle is defective here. Elevated ornithine, glutamine and alanine levels and relatively low levels of citrulline is seen because ornithine trans-carbamylase, what it does, it's going to condense ornithine with carbamoyl phosphate to make citrulline. So because of this deficiency of ornithine trans-carbamylase enzyme deficiency, it will lead to increase in ammonium ion, and whenever there is increase in ammonia levels, there will be increase in glutamine levels, and by transamination process there can be increase in alanine, and ornithine is not condensed, so ornithine levels will be increased. Citrulline is a product of this enzyme, so citrulline levels will be decreased, and most importantly, the elevated carbamoyl phosphate, it will be moving out of mitochondria into the cytoplasm to go into pyrimidine biosynthesis pathway. Let me write it down here. So, bicarbonate combining with ammonium ion in the very first reaction by CPS-I enzyme making carbamoyl phosphate. So I'll just write that carbamoyl phosphate as CP for my future reference here. CP for carbamoyl phosphate. Now this carbamoyl phosphate combines with ornithine to make citrulline. These two reactions are going on in the matrix of mitochondria. Now the citrulline will go out of mitochondria into cytoplasm while ornithine is coming in, and that is done by a single transporter, that is ornithine permease transporter. Transporter name is ornithine permease. It is allowing ornithine to get in while citrulline to move out into the cytoplasm. Now the defect, so that this enzyme here is OTC, ornithine transcarbamylase. So the defect we are seeing here is this enzyme is deficient, so the reaction is down. That leads to increase in ornithine levels, increase in ammonia levels, increase in glutamine levels, okay, and now decrease in citrulline level. All this can be understood. Now what happens is this carbamoyl phosphate, which is also elevated here, that will move out of mitochondria into cytoplasm. So we have carbamoyl phosphate in the cytoplasm now because it will leak out whenever it is accumulating. This carbamoyl phosphate, now it will go into pyrimidine biosynthesis. So I'll just write it as pyrimidine, or let me write what actually it forms. So carbamoyl phosphate entering into pyrimidine biosynthesis, it will make orotate, orotic acid, deprotonated form, orotate, and orotate eventually will go into UMP formation, uridine monophosphate, which is a pyrimidine, and UMP will go into UTP formation, uridine triphosphate, and this uridine triphosphate, whenever it increases, it will have a negative effect on the earlier enzymes. So UTP will have a negative effect on these enzymes. That's a feedback negative effect, and because of that there will be elevation of orotate. So there is increase in orotate in ornithine transcarbamylase deficiency, and this is why you are going to see increase in orotate in the blood and later appearing in the urine. So these are some of the laboratory findings that you are going to see in ornithine transcarbamylase deficiency. So one more time, so there is increase in ammonium ion, increase in glutamine levels, increase in ornithine levels, decrease in citrulline, and most importantly increase in orotate. These are the findings, laboratory findings to diagnose ornithine transcarbamylase enzyme deficiency. Look for that. Other urea cycle disorders other than ornithine transcarbamylase deficiency, let's get into them, these disorders in brief. Hyperammonemia type 1 because of carbamoyl phosphate synthetase 1 enzyme deficiency, where defect in carbamoyl phosphate synthetase 1 is relatively rare metabolic disease leading to severe hyperammonemia. Usually it leads to death. N-acetyl glutamate synthase enzyme deficiency is also noted. A NAG synthase deficiency is indistinguishable from those arising from defect in carbamoyl phosphate synthetase 1 enzyme leading to hyperammonemia, and deficiency in NAG synthase may respond to administration of NAG, because NAG is a obligate activator of carbamoyl phosphate synthetase 1 enzyme, which is also referred as HHH syndrome. Why? Because there are 3 H's here, that is hyperornithinemia, because ornithine permease is the one that will allow ornithine from the cytoplasm to go into the matrix of mitochondria while citrulline is moving out. It's an anti-porter system, which I said in the previous slide. So if that gene is defective, if the gene coding for ornithine permease is defective, that anti-porter system do not work properly. So ornithine levels will be increased in the cytoplasm, and here on the other side, carbamoyl phosphate do not get ornithine in the mitochondria to combine and make citrulline. So because of this, what will happen? So there will be hyperornithinemia, excess ornithine will appear in the blood. Hyperammonemia, because second reaction is not going on in the urea cycle, leading to elevation of ammonia levels in the blood, and also there is homocitrullinuria. So carbamoyl phosphate, which is elevated in the absence of ornithine in the mitochondrial matrix, so will combine with lysine to make homocitrulline, and this homocitrulline will appear in the blood and later appear in the urine. So like this, a HHH syndrome is actually the other name for ornithine permease defect, where hyperornithinemia, hyperammonemia, homocitrullinuria is seen, and this results because of mutation in ornithine permease gene. Now, urea cycle is inoperable due to low ornithine in mitochondria in the absence of its normal acceptor ornithine. Now, let's move on to see citrullinemia. Now, the citrullinemia is also referred as argininosuccinate synthetase enzyme deficiency, where there will be elevated citrulline, and this citrulline will appear in the plasma and cerebrospinal fluid, and there will be around 1 to 2 gram of citrulline which will be excreted per day. So, in citrullinemia, you will have to look for the elevated levels of citrulline in the blood, and also a relatively higher levels of ammonium ion and also glutamine levels. Arginosuccinic aciduria is because of deficiency of arginosuccinate lyase enzyme, where there will be increase in arginosuccinate in the blood, later appearing in the urine. And also one of the characteristic finding that you see here in arginosuccinic aciduria is trichorexis nodosa, where a friable tufted hair is seen. Hyperargininemia is arginase enzyme deficiency. Unlike other urea cycle disorders, the first symptoms of hyperargininemia typically do not appear until 2 to 4 years of age. So, blood levels of arginine will be elevated, and urinary amino acid pattern, which resembles that of lysine citrullinuria, may reflect competition by arginine with lysine and cysteine for reabsorption in the renal tubule. Now, moving on to acquired hyperammonemia. The common cause for acquired hyperammonemia is a liver disease. It may result from acute viral hepatitis, ischemia or hepatotoxins that are affecting the liver, or maybe it due to chronic liver damage caused because of alcoholism, chronic hepatitis, biliary obstruction. Now, the hepatic changes in acute cases may be because of metabolic dysfunction of hepatocytes, leading to decreased urea cycle and increase in the accumulation of ammonia and the metabolic consequences of hyperammonemia. Whereas the hepatic changes that you see in the chronic liver diseases, it is because of shunting of portal blood directly into the systemic circulation, thereby where ammonia is not neutralized in the liver and it is directly going into systemic circulation to cause a systemic effect. So, the detoxification of ammonia is therefore severely impaired in the liver conditions, leading to elevated circulatory ammonia and the consequences of hyperammonemia. Now, coming to our treatment in brief. So, therapy for hyperammonemia can be handled in 3 ways. One is to limit protein intake, thereby a potential buildup of ammonia can be decreased. Second is to remove excess ammonia from the blood by using certain chemicals, where they can go and chelate certain amino acids like glutamine. Glutamine is one of the predominant amino acid in the blood, which is still elevated in hyperammonemic cases. Removing that glutamine out of the circulation, that meaning like removing 2 ammonium ion, every glutamine has 2 ammonium ion, or to replace any intermediates that are missing in the urea cycle. Limiting the protein intake. First thing, when you limit protein intake or give a small amount of protein in small frequent meals, thereby decrease a sudden rise in ammonium ion, so it may control hyperammonemia signs. Or decreasing bacterial source of ammonium in the intestine by using broad spectrum antibiotics, which will sterilize the intestine by killing ammonia producing bacteria. So, will also decrease entry of ammonia into the portal blood, and also use of acidifiers in the colon like lactulose. What this lactulose does is, lactulose is a synthetic disaccharide which is not digested by the intestinal bacteria. Now the other way of decreasing bacterial source of ammonia is use of a compound that acidifies colon, which is example here is lactulose. Lactulose is a synthetic disaccharide. Note that it is not a lactose molecule. Lactose can be digested in the intestine by lactase enzyme, whereas lactulose is not digested by lactase enzyme, but it will be fermented by a bacteria in the intestine into acidic product. So these acidic products will decrease a pH in the intestine, pH of the colon, and when the colonic pH is decreased, so the ammonia which is produced by the bacteria, which has got a pKa of 9.5. When the pH is decreased, so pH will be less than pKa. That means ammonia, which can enter into the colonic epithelium and later getting into the portal system, portal blood, leading to increase in ammonia levels there in the portal blood. So here, because of the decrease in the pH, because of acidifiers of the colon like lactulose acidifying the colon, pH is less than pKa. That means ammonia will be protonated into ammonium ion, and note that ammonium ion in the intestinal lumen is not absorbed because it is absorbed only in the form of ammonia. Now we are converting ammonia into ammonium ion, and this ammonium ion gets out of the intestine in the feces. And that's how we can take out ammonia coming from the bacterial source. Now the use of compounds that binds covalently to amino acids and produce nitrogen containing molecules that are excreted in the urine can be tried, and that is, one is benzoate, which can combine with glycine to make hippurate. Hippurate is excreted in the urine, meaning glycine is taken out of the blood. Phenyl acetate can be used to combine with glutamine to make phenyl acetyl glutamine and removing glutamine from the circulation. And look at the advantage of removing glutamine from the circulation. We have removed 2 ammonium ion because every glutamine has 2 ammonium ion attached. And the metabolic block resulting due to 𝗠𝐼𝐼𝐻 enzyme deficiency can be partially bypassed by supplementing diet with arginine. So 𝗠𝐼𝐻 enzyme is 𝗠𝐼𝐻 lyase enzyme, where we can supplement arginine, thereby you partially bypass the block there. Or rapidly lowering ammonia levels to prevent serious effects on the brain. These include hemodialysis, exchange transfusion, and peritoneal dialysis. Gastrointestinal hemorrhages from dilated esophageal veins, especially in portal systemic encephalopathy, portal hypertension leading to portal hepatic encephalopathy, that needs to be controlled. So like this, various approaches can be used in the treatment of hyperammonemia. So this is all about urea cycle disorders and some of the specific diseases in urea cycle. I hope this video has helped you in understanding this very important concept and the clinical applications of urea cycle. I hope this video has helped you in understanding this very important concept related to urea cycle, that is urea cycle disorders. Thank you.